Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Dr. Brooke Trainer, your host for this conversation with Dr. Diana Mosquera, who's the chair for the Alternative Payment Models Work Group, a part of ASA's Committee on Economics, and Dr. Neeju Ravikant, whose experience with alternative payment models led to the expansion of the pre-op eval and optimization clinic in her institution. She's also a member of the Center for Perioperative Medicine, or CPMed. I've offered here a quick intro to the two of you and what you do, but I'm sure that our listeners would love to get to know you better. So if you don't mind sharing a little bit more about your role and your interest in these alternative payment models.
Sure. Thank you so much, Dr. Trainer. So I am at Albany Medical Center, which is a 700-bed level 1 trauma hospital. I'm an anesthesiologist here. We're located about 2.5 hours north of New York City, and we serve an urban and rural population. I wear a couple of hats here. One of the hats is I'm an associate medical director for value-based care. And what that entails is I essentially collaborate across the hospital and really help oversee programs that tie dollars to quality or outcomes. I also look at readmissions and essentially think about how do we prepare organization to take on financial risk in models that allow us to essentially earn bonuses, etc. I also wear a different hat as an assistant dean for healthcare strategy and clinical transformation. And in that role, I serve as sort of like a catalyst to help advance the projects here that help improve the performance of our faculty practice on models that are tying dollars to quality and patient outcomes, and essentially really focus on increasing access to high quality and efficient care. And then last but not least, I'm an anesthesiologist and I'm at a teaching facility. So I work with residents, medical students in the OR. I work about 2 days a week. And then, as you mentioned, I work with the ASA Committee on Economics, where it's really just a group of really thoughtful, smart, and talented leaders across the U.S. And, really enjoy working with them to kind of think about how do we educate, advocate, and really keep front of mind how different economic topics impact our ability to really provide high quality and efficient anesthesia care for our patients.
And for our audience, you just heard from Dr. Diana Mosquera. And so we're going to hear more from her on this topic in just a moment. But I want to hear also a little background for our audience from Dr. Ravikant.
Yes, thank you, Dr. Trainer. Happy to. I'm Neeju Ravikant. I'm practicing at about an 800-bed hospital in Detroit. Our population is urban, but we also have a large system that extends out into metropolitan, suburban, and we are now acquiring another large system which will almost double our size. So we will be expanding out to several counties in the Metro Detroit area. I am a practicing anesthesiologist. I also teach students and residents. I am the department director, which is sort of a system department, if you will, for pre-surgical optimization and pre-anesthesia testing. And I also serve in the role of the ASA as chair of the Corporate Strategy Work Group and the Corporate Advisory Council for the Center of Perioperative Medicine. And I'm on the board for AQI. That's a long way of saying that I am knee-deep in the clinical implementation of perioperative medicine, what that looks like. And we have launched a successful, really, platform. It was already in place. Of course, in COVID, we took a bit of a backseat, but have managed to really come out swinging with buy-in from surgeons, C-suite, patients, specialists, here to tell all the pros and cons of that, and looking forward to sharing boots on the ground perspective of how that works.
Awesome. So, Dr. Mosquera, I want to start with you. I'm going to ask you to speak about how these alternative payment models, I'll call them APM programs, can advance the goals of healthcare institutions and how they seek to provide value-based care for these institutions.
Yeah, happy to speak on that. So the way that I think about alternative payment models, or APMs, is that they're really a stepping stone away from the constraints on a fee for service and towards a more collaborative and comprehensive care delivery model. An example that I think is relevant to anesthesia is the work that CMS is doing, or the Centers for Medicare and Medicaid Services is doing around episode-based models. Episode-based models essentially focus on discrete care delivery, such as surgical episodes. So one of the models that is most recent is called the Transforming Episode Accountability Model, or TEAM. And that model essentially is an episode-based model. It's mandatory. It started in January 1st of 2026, and it's set to cover around 740 hospitals, or about 1 in 5 hospitals in the U.S. The focus in that model really is how do we deliver care in a way that once that surgical procedure is delivered and the patient is out of surgery, how do you transition that patient back from the principal provider to that patient's primary care? That's a key focus of the program, that kind of transition. So there you can see how that key component and really common theme or thread around making care more collaborative and more comprehensive comes through. I think that this is something that also makes sense for all healthcare institutions. It can impact important drivers of the bottom line, such as length of stay, readmissions, complication rates, adverse events, and overall patient satisfaction. This is something that I think is important regardless of what type of environment you are practicing in. And these factors are really top of mind for all leaders that are essentially looking at healthcare across, the spectrum of different types of delivery models. So in essence, I look at APM programs as a stepping stone away from this constraint of fee-for-service, but also it does resonate with general goals and the targets that hospitals and hospital executives are also looking at.
So how do these APM programs intersect with like the broader operational or financial goals of these hospitals?
So I think the first piece is that a lot of these programs really have evolved to have a quality focus. So from an operations standpoint, the quality metrics that they're going after, they need to be pretty high level and really align with overall goals that cross in the hospital. So things like readmission, safety, the patient experience. And so these are factors that in an era where patients are looking up their hospitals, looking at their providers and their physicians, these are factors that help, across the board. So they can help a consumer that's looking for a better experience. If you have good readmission scores, if you're known to have high quality and patient safety front of mind, these are things that help in these type of programs, but also help drive that patient satisfaction, that trust in the care that they're providing, et cetera. From an operational standpoint, I think that in an era where we can all agree that there's high demand for care, resources are definitely limited, there's increased complexity in patients, this concept of moving care to the appropriate setting resonates both with alternative payments, but also with operations and finance goals of healthcare institutions. Alternative payment models, or APMs, often focus on things like shared savings. So if you're able to come up with workflows that can help do things like decrease length of stay or keep a patient in the community or in an ambulatory care setting, by doing that, you're aligning not just what the APMs are trying to get you to do, but also the things that overall make sense for the hospital's bottom line.
And so what about the patients in all of this? How are the patients impacted with these payment models?
Well, I think that the patients are impacted in a way that, the evolution of this idea of value has really gone from just incorporating process measures or to looking at quality, looking at safety, and increasingly really looking at things like patient-reported outcomes. For example, in the T model, one of the measures is a measure that looks at how patients rate their mobility and their pain levels after a surgery. And so that shows that a lot of this movement sort of is taking into account the patient experience. A lot of APMs also take into account things like HCAHPS scores, which are the surveys that patients fill out after they receive healthcare service. And in that way, they really are helping us shift this focus from getting a patient into the OR and just through the surgery, but really thinking about how do we expand our impact in that perioperative journey. And, as anesthesiologists, how do we think about in agile terms to how do we improve that patient's experience across the board from before they go into surgery and during and after the surgery?
Dr. Mosquera, I'm curious, is the APM models really centered more around hospitals, systems, and can it be applied? And do you foresee it being utilized and applied to ambulatory surgery centers, these smaller surgery centers, endoscopy centers, outpatient settings?
Yeah, that's a phenomenal question because I think we use the term APMs, but we fail to recognize that it can be used to describe many different types of arrangements where you're paying in a way that is more innovative than just fee for service. So to answer your question, yes, there are different flavors of APM. So for example, there's APMs that are very focused around hospitals. Those are programs that are what we call accountable care organization type programs that essentially look at an overall budget or cost for a patient population and then sort of compare your quality and if you were able to stay within that budget. Increasingly, the Centers for Medicare and Medicaid Services, which, by the way, is the largest health insurer in our country and really drives a lot of what happens in healthcare around payments, is looking to engage more specialty services. So, for example, this T model is one approach of doing that, of trying to, how do you move specialty services into value? Of course, I would be remiss to not mention primary care. So primary care has been a huge target, really, for these APM models, as we know that there's a need to help incentivize primary care in a way that helps patients get a more holistic experience and really trying to target more of those outcomes rather than just paying for every single visit that they go to, their doctor.
Exactly. And bringing it back to primary care as like the center of the hub of the wheel really, I think, does help align patients' needs and focus that patient needs along with that payment model. So that's very interesting. I'm going to turn it over to Dr. Ravikant here. I wanted to make sure you have an opportunity to speak about your experience in starting and enhancing the pre-op evaluation in your hospital. And I know you talked about the pre-op clinic optimization program. Can you talk a little bit more about what you hoped it would achieve and sketch out for our listeners what that success looks like?
Yes, Dr. Trainer, I'd be happy to. I think I mentioned that when I joined Henry Ford, it was right in the middle of COVID. So the clinic was a pretty slow place. We had just a few patients. The priorities were, as you can imagine, for a large tertiary care level 1 trauma center, very, very different. But that really was an opportunity. So I'd like to give the listeners hope that when you are in the middle of something that doesn't exist, there's only one way to go, which is up. So what it gave me time to do with partners and leaders in the space was to say, what could we do in a different way? So, for example, we now, 4.5 years later, we've gone from maybe, at that time, 2 to 3 patients, perhaps. We're now at close to 37 patients a day and probably will be upwards of 40 to 50 once we're at full scale. So that is the trajectory that is possible. But we did have to do a couple things in between. One of the things we had to do was say what we wanted to achieve. We did have protocols on anemia avoidance and glycemic control, other things like cognition, identifying conditions that were not appreciated before boarding and the implications of it not being understood, such as cardiac conditions, hepatic conditions, renal conditions, really head to toe. So we knew that's what we wanted to do. We had some protocols about what we would do if there was iron deficient anemia, what we wouldn't do, what would we do for A1Cs or indications of blood sugar control that were not appropriate, how would we handle those discussions? But the challenge we had was how are we going to see the patients that we want to see? So what we did, again, very close partnership with surgical services here at Henry Ford, was to create a risk stratification tool. So it was a novel tool that stratifies both the surgical acuity as well as different comorbidities. It scores both of them. And the EMR that we use, Epic, will calculate a combined score reflecting where that patient is on a risk or an acuity scale that allows us to triage the patient to the right team. So, for example, as you can imagine, in COVID, we did not have an opportunity to hire and put a lot of funds towards this. So we needed to make the most of the team that we had. And so what the risk tool allowed us to do was to send low and moderate patients to PAT nurses, pre-admission testing nurses that we trained, that have been just frankly superb at understanding how to look at patients who have lower acuity, how to look at their conditions, mine the chart, know what to look for, know how to close loops with either bumping up to an anesthesiologist or an APP, and really creating a process for them. We then also hired fantastic APPs and who we trained in how to manage the high-risk patients. And you need this sort of scalability in order to go from 4 or 5 patients to, up to 40 patients a day. So that was important, the process of how we would identify and move patients through the clinic. The next thing we had to do was figure out, well, okay, we know who we want to see. We want to see all the high risk, but how do we get them here? And that was another sort of innovative approach. And again, in close partnership with surgical services to say, well, if a patient is high risk, they should automatically be referred to the clinic. And that is really what allowed us to see the patients we needed to see and not wait for a referral or have it missed. So there was that innovation. And then after that, it really came pretty fast and furious because, keep in mind that along with us are surgeons having to deal with how to live in those APMs that you heard Dr. Mosquera mention, whether it's MIPS or value-based reimbursement or bundle payments, whatever terminology you're using, it's just a different conversation from fee for service. So while you want to do a successful surgery and provide that outcome, you will increasingly, as a surgeon, have to be accountable for anemia, glycemic control, cognition, length of stay, discharge to a long-term care facility, why, for how long. So we came at the right time because their buy-in was tremendous. It was sort of, in a word, well, can't believe you're going to handle all this and do it effectively. Keep me on time for aborted case, or if not, you're going to tell me why, have discussions, and allow me to also run my practice and take care of patients in a timely manner. So everything from sort of a clinical goal, operational feasibility, and a practical lens to how things work in the OR. And as all of us know as anesthesiologists, there's a practical component that you have to live in. Delaying cases inevitably is not going to be feasible for a perfect scenario. There are things that you have to balance, and I think that's why anesthesiologists are uniquely suited for this role. We do this on a daily basis. And so that speaks to sort of how we got to where we are.
It's really interesting. I'm thinking about this in terms of other institutions as well, like how some of these protocols and this risk stratification tool that you implemented can be replicated. So is this replicatable? Can all clinics scale like this? Can you talk about that a little bit?
Yeah, I think that it is replicatable and it is scalable. I think the biggest hurdle is honestly wanting to take it on. I want to give listeners really, again, very deep optimism about where you sit in the marketplace and the professional landscape right now, which is it is very hard to deliver this with your lens. So if you are going to step up and say, we will deliver this, and of course, if you could show a positive return on investment, which we did. We were funded extremely well and are outpacing projections. If you can do that as well, it's quite doable. So I think the first thing you would do is on a smaller scale is pick a service, whether it's a high volume, short turnover service, whether it's a high acuity service. Pick something that the expertise in your practice is well suited to support. Talk to your partners about As we all know, what kind of FTE dedication would you need? Do you need APPs, more RNs? How to scale the visits in a way that would provide a positive return on investment for the facility. I think it's very scalable, but starting small is a good idea. I think you'll be pleasantly surprised with how fast you'll grow.
So I'm curious, you mentioned about the ROI on this clinic and this idea and making sure that it's funded well. And most of these funds, I'm imagining, are bundled into these episodic payment models. So how, as an anesthesia group, let's just say that anesthesia group is a private group that's separate from the hospital or that's separate even from the surgery group. If the surgeon, for example, is the one getting that episodic payment, how do you divide up that for this initiative? How does that get funded?
Yeah, that is a fantastic question. It is a mind shift, right? It's a different perspective. It's not just that we're going to do perioperative medicine tomorrow and that's it. You are now and will enter office-based care. You are a clinic. So as these patients come in, you bill for those services just as a medicine clinic would or a nephrology clinic. That is the revenue that you are generating. Now, there is also downstream revenue. If you wanted to chase that, I wouldn't suggest that up front, but there's a tremendous amount of downstream revenue if, for example, you are providing CQI or collaborative quality initiatives that each surgical service has. And for example, your neurosurgeons might have chosen anemia avoidance and glycemic controls. So when you are the clinic that says, okay, this is our protocol for, let's say, an A1C of 8 or less for elective surgeries and an anemia of, it should be hemoglobin should be 10 or greater. And if it's microcytic, we'll do this. And if it's macrocytic, we'll do that. They are able to use those protocols to submit proof of their participation in value-based care. And there are incentives for them for that. And you have provided that and generated revenue based on the clinic visit. So that is one model. Certainly downstream revenue additionally, not only the value-based reimbursement that the surgical specialties are able to capture based on the metrics that they've chosen. Other things are also data capture, length of stay, reduction of unanticipated admissions. In other words, if you were supposed to go home, you did not go to 23-hour OBS. If you were supposed to be admitted, you did not escalate to ICU. So these are downstream revenue, and there are costs attached to those that you can then provide as your return on investment. Other downstream revenues are certainly the consult studies and labs that you might order to support your assessment. So I hope that answers that there are many ways to go at it. But again, best to start small and go big.
Yeah, that sounds like something that should entice a lot of the groups. So how do you earn that buy-in? And how have you demonstrated the program's value since it's been up and running?
So that's a fantastic question because that too is a shift in mindset. So when you are running a clinic, that means you provide a service that is extremely quick. Your hours are not necessarily when you hit the OR and when you go home. They might be a little past that. So you need to have engaged members that you bring on to your team, but you are efficient. You bring tremendous insight into what's going on, how acute this case is. There's a difference perhaps between hidradenitis excision versus one that is purulent and causing white counts and their diabetes to skyrocket. Understanding that clinical lens is what gives you tremendous credibility to your colleagues. They understand that you are not going to be delaying cases for the wrong reasons. And if you are considering it, you have that working relationship with them. You work with them in the OR 24/7. So your ability to pick up the phone and speak to them about, okay, what's really going on? It's a very welcome interaction, I think, personally, for specialties in an OR that have become siloed sometimes due to just the nature of healthcare. And it is a collegial relationship about how do we get this done in real time with real life sensibility.
So where can listeners go to learn more about starting up one of these preoperative optimization clinics? Is there a designated place that you can refer them to?
Yes. So the Center for Perioperative Medicine, CPMed, is a very ambitious collaborative under ASA. It's really taken off in a very short period of time. You can access the CPMed site on ASA HQ under the Managing Your Practice tab that will allow you to see some of those materials. We are developing them as we go. Certainly, I'm happy to share my contact information. Feel free to reach out. There is a component, I think, for our colleagues where they feel like, boy, this is probably tailored to an academic center or to a very large group with very large resources. And we're very passionate at CPMed to dismantle that myth. There is a way to do this, but it might be by picking up the phone and talking to people who are doing it. So again, happy to share my information.
In a similar lens, I think that if you go to the ASA website, there's the alternative payment models subsection that you can find through the website, the ASA HQ website. And there we have things like explaining what population health is, explaining different aspects of value-based care, and we are constantly looking to add resources to that, as well as collaborate across different committees within the ASA to find those areas of synergy that we know exist. And as you think about how to start up the clinic, how to build a perioperative medicine model, it's also important to know what are the types of programs already out there for payment that I can essentially reference as I'm trying to get that buy-in from surgery, from the administration. If you know that maybe your hospital is in some form of APM already, that will help you essentially formulate a strategy to show how your perioperative medicine or optimization program can help drive and align with those goals.
And this has been incredibly helpful for even myself. I mean, this is something most of us do not learn in medical school, as you know. So having those resources, having experts like yourselves to share that valuable information is just so helpful. And I know we need to wrap up, but before I let you go, I'm just wondering if either of you or both of you want to take a moment to bust some myths. Is there something about the APMs that you want to tell your fellow anesthesiologists so that they can understand better, folks like myself?
I think that the myth, not even a myth anymore, it really is a reality. Many years ago, we talked about value-based reimbursement, that it was coming and that fee-for-service would go away. And we talked about preparing, but frankly, fee-for-service was in place. It didn't look like it was going anywhere. That is no longer on the horizon. It is very firmly here. If you look at what private payers, what CMS is doing, and certainly if you understand the business approach as to why they would do it, it would make sense in addition to quality care for patients. So the myth that we could probably not do this stuff or it's just for people who are interested in it, I would say very squarely that this is about the survival of your practice, to support all the families that your practice includes, to be able to provide care in a different way is really required. This is an evolution that is overdue, and it's going to be exciting.
You know, just to support that, I'd say that in 2023, the Healthcare Learning Action Network, it's essentially a body that surveys every year what's going on in the insurance marketplace. And based on 2023 data that essentially covers about 97% of the insurance market, they showed that about 60% of payments across commercial and public payers like Medicare, Medicaid were flowing through some form of either of payments tied to quality or an alternative payment model. So I think it's totally to Dr. Ravikant's point. I think another myth I would like to just address is that a lot of times we feel like we can't take on some of these roles, or how do we as anesthesiologists think about this new landscape? And I think that our strength is that we by nature are a cross-sectional specialty. We work across different types of surgical care, different types of providers, and I think we can use that cross-sectional skill set to our advantage. As you've heard from Dr. Ravikant, a lot of the work that is needed to succeed in any kind of alternative payment model is really all about busting out of silos and figuring out how do we optimize our resources. And so I think that with that in mind, we often think that value is this overused word, similar to, I think, how we now use AI for everything. And I think that we kind of have to step away from thinking that value is this overused kind of theme and really embrace it. Because I think that at the core of it, you're really thinking about how do we shift our way of thinking to really deliver care in a way that optimizes outcomes while using either the same inputs or perhaps less inputs or resources. And ultimately that, I think, helps not just patients first and foremost, but I think as providers, as anesthesiologists, as physicians, we all walk away feeling a lot better if we think the care we're providing is coordinated, is collaborative versus care that feels very siloed and constrained, which is what a lot of some of the fee-for-service sort of base models offer.
Absolutely. And that's such a great way of putting it into perspective. So I just want to thank both of you so much for joining me today, helping to enlighten our listeners as well as me. I certainly learned a lot. I'm sure our listeners did too. So Dr. Ravikant mentioned where to find the CP Med page, but you can also find the APM info under the Managing Your Practice tab on asahq.org. Please come back soon for more Central Line. Thank you.
Awesome. Thank you.
Thank you.
ASA's leading coding and billing resources belong in every anesthesia practice and can pay for themselves by assuring appropriate payment for each procedure, improving compliance, and reducing time spent resubmitting claims. Order your 2025 copies of Relative Value Guide and Crosswalk now at asahq.org/coding. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.